Good morning, everyone. I'm Johnn Herrera, a surgical oncologist from the University Hospital of Palencia in Spain and the Upper GI Working Group representative at the Education and Training Committee from the European Society of Surgical Oncology. Today, my mission is to synthesize the most impactful evidence from recent trials across gastric, e.g. junction, and esophageal cancers, and how they are reshaping surgical decision-making. Today, we are going to speak about anastomosis after esophagectomy, the use of fluorescence, the use of drains, sparing techniques, and rehabilitation, quality of life, and postoperative recovery. This randomized trial from the Netherlands included 245 patients randomized in intrathoracic versus cervical anastomosis after minimal invasive esophagectomy, and showed lower complications and cost-effectiveness favoring intrathoracic over cervical anastomosis. In this table, we can see the difference in both healthcare and societal costs at both 9 and 21 months respectively. In this figure, we can see the probability that the minimal invasive esophagectomy with intrathoracic anastomosis is cost-effective. The class 11 randomized trial is a multi-center open-label trial, and it showed improved lymph node yield with comparative safety when performing a lymph node dissection guided by ICG in gastric cancer patients, 46 versus 37 lymph node retrieved. The FAIS-12 trial demonstrated oncological safety and feasibility. There was an improved 5-year overall and disease-free survival. This is raw data, and this is data adjusted by tumor location, and a reduced cumulative incidence of early recurrence in gastric cancer patients. These results push integration of ICG into routine minimally invasive workflows. To drain or not to drain? That is the question. Let's see what's new about this subject. While previous trends moved toward omitting drains, mainly due to the ERAS protocols, the ADG multicentric randomized trial found higher postoperative interventions in the non-drain group. 400 patients randomized into groups, drain and non-drain. In the non-drain group, there was an increased need for escalation in the level of care and a higher 90-day mortality rate. This suggests that selective drainage, not routine omission, may be safer, particularly in higher risk patients and in settings where advanced disease is more common, like in Europe or America, for example. But we are not only looking for cure, right? We also need to provide quality of life to our patients. And some teams are studying how to improve this. Let's see what they are found. In this multicenter randomized trial, 251 patients were randomized into two groups, the pylorus-preserving gastrectomy and the distal gastrectomy. Authors found significantly less gallstone formation, nutritional deficit, and bile reflux. And in general, there were no more postoperative complications with this type of procedure. There was no difference in the dumping syndrome, as we can see here in the first table, and nor quality of life. However, when an endoscopic assessment was performed, there was more delayed gastric emptying and reflux esophagitis with pylorus-preserving gastrectomy. This study confirms that pylorus-preserving gastrectomy is oncologically safe in early gastric cancer patients when located in the middle portion of the stomach, with comparable overall and disease-free survivals in comparison with distal gastrectomy. Although this is interesting, we need to highlight some important facts about this study. First, the strict inclusion criteria and surgeon qualification process may limit the generalizability of these findings. Second, Lymph node dissection, especially in the infrapyloric area, requires expertise. Third, the follow-up period is only 3 years. And finally, the study was not blinded, so we need to consider these findings carefully. This is an open-label randomized trial which included 264 patients which were randomized into two groups, vagus-preserving gastrectomy and vagus-resecting gastrectomy. The study found that with vagus-preserving gastrectomy there is a short-term significant reduction in gastroparesis and gallstone formation, as well as better quality of life for gastric cancer patients. We need to say that most patients in this study were early gastric cancer patients, and that the follow-up period of this study is only 12 months, so we need to wait for the long-term oncological outcomes. This study was conducted in a high-volume single institution in China, limiting the generalizability of these findings, not only because of the volume, but also because of the characteristics of the patients. Well, this is not a randomized trial, but I think that the concept being studied worth mentioning. After a gastrectomy, there is a decreased oral intake, mainly due to 3 causes: a small remnant stomach, a decreased gastric function, both mechanically and digestive, but also endocrine because there is a lack of ghrelin, which regulates the appetite. So the authors propose preserving part of the stomach may improve this problem, as you can see here in the image. And they concluded that this approach is safe to perform, preserve ghrelin secretion, and therefore preserve appetite and lean body mass. But there are some concerns that we need to talk about. This is very small sample size in a single center and single arm design. And besides this, and more importantly, we need to talk about the oncological part of the procedure, because lymph node station 4SA and 10 are not dissected. So, although the metastasis rate for station 4SA is reported to be low, less than 5%, the risk of recurrence in these regions remain a concern. So we need to wait for more studies like this. Regarding prehabilitation, quality of life, and postoperative recovery, well, we need to optimize our patients to prehabilitate them. So we are going to take a look at a couple of studies. This multicenter randomized trial included 79 patients that were randomized into 2 groups, high-intensity interval training and standard of care. And this study showed that there are improved pulmonary outcomes with structured prehabilitation that use high-intensity interval training, even when they with short time frames, because in this study the patients did this protocol for 2 weeks. So even with short time, it is impactful. And this other study, this is another randomized trial. It included 22 patients with locally advanced esophageal cancer who were randomized to prehabilitation or standard of care. They found that prehabilitation not only promotes higher levels of respiratory fitness, but also changes the tumoral microenvironment with an enhanced CD8 and natural killer infiltration, suggesting that prehabilitation during neoadjuvant chemotherapy can enhance the immune system, and this could have positive implications when using immunotherapy. So prehabilitation and immune conditioning are emerging evidence and probably will reshape preoperative planning and prehabilitation standards in the near future. Regarding quality of life and postoperative recovery, in this first study, which is a randomized trial, the authors found that there is a benefit from jejunal feeding over early oral feeding with less body weight loss, higher calorie and protein intake, and less malnutrition stayed in the esophagectomy patients. The postoperative outcomes and quality of life were similar in both groups. In the second study, 85 patients were randomized in two groups, experimental and standard. The experimental group received a 12-week program of walking and diet. The author found that the program improved quality of life, rest activity, circadian rhythm, and sleep at 1 year follow-up. And finally, the third study included 198 patients randomized in the experimental and standard group. The authors found that the psychological and sleep interventions reduced anxiety and improved not only sleep scores but also immunological and inflammatory profiles, which may play a role in postoperative recovery and long-term disease control. I will also give you a bonus, a glimpse into the future. I've been thinking about this for a long time, and I was wondering when this type of therapy would come to the upper GI malignancies, and they finally arrived. So the intraperitoneal use of CAR T-cell is being tried preclinically now. Intraperitoneal low-dose CAR T-cell administration achieves superior antitumor efficacy, longer survival, and sustained functional persistence compared with systemic administration. Also, the intraperitoneal treatment exhibits power against distant disease, not only intraperitoneal disease. And what I found really interesting is that the authors of this study are already evaluating intraperitoneal administration of CAR T cells in patients with GE junction cancer with peritoneal carcinomatosis. So we need to be aware of this, and we are waiting for the findings already. This is just to mention some studies already published during 2026. The first study identified that higher expression of beta-adrenergic receptor is associated with improved survival for esophageal adenocarcinoma patients treated with neoadjuvant chemotherapy and surgery. This has implications in surveillance. It can also work as a therapeutic target, and it can have implications also in prognosis. This second study, this is from ASCO. I'm going to show this to the clinical oncologists in our MDT. We know that in elderly patients, sometimes giving chemotherapy is hard, but this study found out that in high-risk patients, especially in elderly patients, appropriate dose modification may be useful. And finally, this study, Infinity study, showed that feasibility and promising results that could change the treatment paradigm for locally advanced gastric cancer and EG junction cancer with deficiency mismatch repair and MSI high status. The study found a high pathological complete response rates and encouraging long-term outcomes with preoperative chemotherapy-free immunotherapy. These findings encouraged the investigation of organ sparing or non-operative approaches in the near future. So what have changed in 2025? Well, intrathoracic anastomosis has shown to be safer and cost-effective when compared to cervical anastomosis. Living in a drain is not a sin anymore. ICG can help us both in the short and long-term outcomes. Non-operative management could be a possibility in the near future in selected cases, and flexibility and adjustments can benefit elderly patients. Key takeaway for you guys: guidelines are evolving faster than ever, function sparing and tech-enhanced surgeries are rising, immune selection is evolving fast, and we must integrate biomarkers into planning. Some questions for you. How do you think the landscape of upper gastrointestinal malignancies would look like in 2028? What problems is your MDT currently facing? And what do you think is the main limitation of current guidelines and their implementation? Thank you very much.